Firstly, we will learn some basics regarding cardiac action potential.
The first phase of a cardiac action potential starts with depolarization, in which majorly sodium channels open and there is an influx of sodium ions into the cell. So due to this positive charge influx, there is a rise in the membrane potential, and a minor contribution is done from calcium ions, which also move into the cell. And in phase 2, potassium channels start to open, and these potassium channels will allow potassium to go outside the cell. But this phase of repolarization is divided into two, which in phase 2 the repolarization is a bit slower, and then it picks up the pace, and in phase 3 repolarization is rapid. This occurs because in phase 2 the calcium channels are still open, and the positive charge loss due to potassium moving outside will somewhat be counteracted by calcium influx. But in phase 3 these calcium channels close and the potassium will rapidly go out of the cell, leading to rapid repolarization phase. In phase 4 there is a bit of hyperpolarization due to the leaky potassium channels, and then the action potential reaches to its baseline, which is called as the resting potential. Usually until phase 3, even if cardiac muscle is stimulated, action potential cannot be initiated because
Cardiac muscle will be in absolute refractory period.
in this absolute refractory period a second action potential cannot be initiated. Coming to pathology of Torsades D points, prolonged QT interval directly denotes a prolonged repolarization phase. Due to this prolongation in the repolarization phase, this prolongation gives a chance for the development of early after depolarizations. What's meant by an early after depolarization? Either in phase 2 or phase 3, due to the defects in ion channels, in phase 2 calcium channels opening is abnormally prolonged. So this leads to prolonged phase 2. Or in phase 3, due to defects in ion channels, sodium channels will start opening in phase 3. So there is a positive charge influx, and this leads to prolongation of phase 3. And when this phase 2 or phase 3 is prolonged, look at this diagram. In repolarization, either in phase 2 or phase 3, if it's prolonged, either maybe due to increased latency of calcium channels or opening of the sodium channels in phase 3, depolarization, which is supposed to happen after completion of phase 4, starts very early, either in phase 2 or in phase 3. The absolute refractory state, which is maintained until phase 3, will be lost, and cardiac myocyte will be stimulated prematurely. These early after depolarizations, when they reach the threshold, they stimulate the cardiac muscle leading to a premature ventricular contraction called as PVC. When these EADs, if they don't reach the threshold, they can be seen in the ECG as tall U waves, and if these reach the threshold, they manifest as a premature ventricular contraction. We have learned that Torsades D points can be caused due to various reasons, either by medications or some cardiac conditions, or in metabolite abnormalities, or in bradyarrhythmias. For a classical TDP, Torsades D point is to occur, the characteristic initiation sequence is pause dependent,
And it also exhibits R on T phenomenon.
What does this pause dependency and R on T phenomenon means? Have a look at this image. This image is the rhythm strip of a patient with drug-induced TDP. Here, after a normal QRS complex, we learned that due to prolonged QT interval and due to early after depolarizations, there is a development of ectopic beats called PVCs. After a normal QRS complex, due to that phenomenon of EADs, a PVC has developed. After this PVC, there will be a long pause before a normal QRS complex again. And when this characteristic pattern of a short interval before the PVC and a long interval after the PVC before normal QRS develop, then at the end of the normal QRS complex, the abnormal PVC will overlap on the T wave, and this gives rise to a Torsades T pointis. This characteristic short, long and short ventricular cycle will be the initiating factor for TDP. This characteristic initiation is given by the names of pause dependent TDP or a TDP with R on T phenomenon. Why is it called pause dependent? Because after the ectopic PVC, there is a long post ectopic pause, which characteristically occurs before the development of TDP. The onset of TDP is often preceded by sequence of short, long, short RR intervals, so-called pause-dependent TDP. And this R on T phenomenon is explained by after the normal QRS complex, there is a T wave on which this ectopic R wave has overlapped. Hence the name R on T phenomenon. Even if it's an ectopic, a positive deflection is always denoted by capital R. So this positive deflection is overlapping the T wave, so it's called as R on T phenomenon. To be clear on this, we will see a rhythm strip from Harrison explaining TDP. This part A is an ECG of 2:1 AV block. We can see by the arrows, not all P waves are progressing to QRS. Some P waves are being blocked. Every alternate P wave is blocked, so the block is 2:1 block. Due to this block, the QT interval is abnormally prolonged, which is way more than our threshold of 440 milliseconds. So this patient is a potential candidate for developing TDP. This B shows the telemetry rhythm strip of the same patient. Here we can see after a normal QRS complex, there is a development of PVC, and we have learned that this PVC is due to EADs, which in turn is due to defective ion channels. After the development of PVC, there is a long pause before the next QRS complex, and shortly after the normal QRS, the ectopic is overlapping the T wave and it initiates the TDP rhythm. So now we can understand what's meant by short, long, short RR interval and pause dependent TDP, and what's an R on T phenomenon. We can see these three things in this rhythm strip. There is characteristic short, long and short interval before the development of TDP, and this development of TDP is characteristically dependent on this long post-ectopic pause, so it's called a pause dependent TDP, and the first ectopic is overlapping T, which explains the R on T phenomenon. That's the pathophysiology of TDP. And how do these patients present in a hospital setting? They typically present with a near syncope or a syncope or directly with a cardiac arrest. Usually a classical TDP is short-lived. But if this TDP is sustained, then these episodes degenerate to ventricular fibrillation. and this ventricular fibrillation is a serious condition which requires defibrillation. So PVCs and non-sustained VT, they often precede the episodes of sustained VT, which is a much more serious condition. So what's the treatment? If there are recurrent episodes, then IV administration of 1 to 2 grams of magnesium sulfate will usually suppress the recurrent episodes. If magnesium alone is ineffective, then we can try other different methods like increasing the heart rate either by isoproterenol infusion or by pacing. And why the increasing heart rate will help in suppressing the PVCs? Because automatically QT interval will be shortened, and this suppresses the PVCs, and which indirectly suppresses the VT recurrences.
So these are the most important points regarding Torsades depointers, and thank you for watching.